بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. نفتتح الجلسة الأولى ونشرف بأن يكون first speaker دكتور أشرف أمين. His talk will be about abdominal compartment syndrome. تفضل دكتور أشرف.
For this coming few minutes, I'd like to shed light on important topic, abdominal compartment syndrome. Let's just give one question for my colleagues and my seniors. How many times did you face a case of abdominal compartment syndrome in your practice? Nobody? محدش شاف حاجة خالص؟ Abdominal compartment syndrome. Yes, thank you. So, should we worry about it? Thank you. What to worry about and why should we worry? When to worry and when to worry more? And why to worry? And regarding treatment, what, how, why, when, and where also. Actually, it's a problem, a big problem, because the significant imbalance between prediction and prevention, between presence and detection or diagnosis, between management and its diagnosis, between intensivist and surgeon. Why to worry? Because we have a different or misunderstanding or some lack of information regarding the diagnosis. So what is the diagnosis and definition? Intra-abdominal pressure is a sustained or repeated pathological elevation of intra-abdominal pressure more than 12 millimeters. And abdominal compartment syndrome, by definition, abdominal compartment syndrome is sustained intra-abdominal hypertension more than 20 millimeter mercury with worsening organ function. Can be classified to primary or secondary according to the pathology. And the current recommendation for categorization, we have normal pressure 0 to 5, mild elevation in most of ICU patients from 6 to 11, and intra-abdominal hypertension, the cutoff value is more than or equal 12 millimeters. Grading from mild to moderate and severe. Abdominal compartment syndrome, it is not a disease. It is a condition. And why that? Because the abdominal cavity, as all of you know, is a neglected compartment. Regarding the history, it started maybe in 1811 from Volkmann ischemic contracture, when he thought about the ischemia resulting from the increased pressure, and start to have thoughts and ideas about abdominal compartment syndrome from 1863 and going on till the foundation for World Abdominal Compartment Syndrome Society and their guidelines. So why should we worry? And it is common or rare actually, and for surgical patient or medical patient, previously it was thought as a disease of surgery or trauma patient, but nowadays it is more common and more prevalent in medical conditions also. Why that? Because unrecognized abdominal compartment syndrome is 100% mortality, and timely diagnosis and intervention can reduce mortality by more than 50%. Not only that, with decompressive laparotomy, organ dysfunction typically improved transiently, but most patients developed a second hit with multi-organ dysfunction and failure. Development of intra-abdominal hypertension is an independent risk factor for death. Should we worry? Should be sad for the previous mentioned information? Actually, the coming is more. Since 1990s, abdominal compartment syndrome was recognized as a significant clinical problem. And more recent studies indicate that despite early recognition, decompression, and the outcome is still poor. And not surprisingly, surgeons are reluctant, and sorry for that, to make decisions regarding decompression based only on measurement of intra-abdominal pressure. So what is solution is prediction of the problem, not treating the problem. The early and accurate prediction is important to identify risk factors and to concentrate on preventive measures. When to worry? Because if you think about the mechanism for diminished abdominal wall compliance, increased abdominal or intraluminal contents, capillary leak, or fluid resuscitation. A lot of risk factors, maybe all of our patients have one or more of these risk factors. But when to worry more? For specific situations like acute pancreatitis, trauma patient, burn, obesity, and pregnancy. Prevention, a lot of measures have to be tackled together. And for primary abdominal compartment syndrome, can we decrease it? By increasing awareness and focused monitoring, application of temporary abdominal closure methods, fine-tuning of resuscitation. For secondary abdominal compartment syndrome, it is equal to failure of resuscitation, either over-resuscitation or neglected hemorrhage control or non-existent monitoring of abdominal compartment syndrome. Worsening of respiratory and or renal function, we should put in our differential diagnosis abdominal compartment syndrome. So if you have your patient developing acute kidney injury, not just call the nephrologist to manage the situation, but you should put in your differential diagnosis could be abdominal compartment syndrome. And secondary abdominal compartment syndrome in specific situations like what we mentioned before, burn, trauma, and shock patient in ICU, it equals to a negative performance indicator. Why to worry? Because abdominal compartment syndrome can end by multi-organ dysfunction and failure. For increasing intra-abdominal pressure, definitely will decrease the cardiac output. So if you have intra-abdominal pressure of 15, the cardiac output will decrease by 20% from the baseline. And if you have intra-abdominal pressure of 20 millimeter mercury, the cardiac output will significantly decrease up to 70% from the baseline. Not only that, but hemodynamic parameters, which you can tackle, you can measure blood pressure, you can even measure the cardiac output, alone do not reflect the extent of the problem. Regarding the animal studies, before reveals a significant fall in blood supply to the liver at intra-abdominal pressure of 10. And for the intestine, the blood supply is significantly decreased at intra-abdominal pressure of 20. Not only that, but the gut mucosal pH decreased significantly to 7.16 at pressure of 20 and to 6.89 at pressure of 40. What does it mean to have significant acidosis? Means the oxygenation or the oxygen supply for these vital tissues is decreasing significantly up to 2% of the baseline. Before overt clinical signs, the internal intra-abdominal organs are becoming ischemic. In human, abnormal gastric intracellular pH has a strong correlation with intra-abdominal pressure above 15. Organ dysfunction and definitely poor outcome. Clinical presentation, so you have different, but actually clinical examination has very poor predictor for abdominal compartment syndrome. So do not wait for clinical signs of abdominal compartment syndrome. Otherwise, you will be too late. Radiology might give you a hint, but it is not specific. The definitive diagnosis of intra-abdominal hypertension and abdominal compartment syndrome requires measurement of intra-abdominal pressure. We have different models for measuring the intra-abdominal pressure, but what is the indication to check the intra-abdominal pressure? You have 1 of 2 plus 2. So if you have your patient just newly admitted to the ICU, or evidence of clinical deterioration, plus at least 2 risk factors which previously mentioned, as all our patients there, so you need to check. How can we monitor the intra-abdominal pressure? Either direct by, and this is only during experimental or during laparoscopy. And direct, which is the baseline and gold standard currently, is through the urinary bladder. So what is the treatment? We have non-surgical percutaneous interventions and surgical decompression. So this algorithm start by measuring intra-abdominal pressure. If it is 12 or more, or present or less than 12. If less than 12, what you need to monitor the intra-abdominal pressure, because you might have a secondary abdominal compartment syndrome later on. If the intra-abdominal pressure is 12 or more, so you should initiate treatment. So what treatment? You need to identify and treat the underlying etiology. If it is primary abdominal compartment syndrome, which is your interest as a surgeon most of the time, so in these situations, you might go straight forward for surgical intervention. But the problem comes when it is secondary abdominal compartment syndrome. What treatment? We have some highlights regarding the evacuation of the intraluminal contents by different methods like inserting NG or rectal tube. Prokinetics minimize enteral feeding, or sometimes you need to stop it. Colonic decompensation. And if no response, definitely you need to go straight forward for surgical decompression. You might need to evacuate the intra-abdominal space occupying lesions like a collection. You need to put pigtail or something like this. Improve the abdominal wall compliance, some sedation, pain killers, positioning, and sometimes your patient and ventilator, you might need to give some muscle relaxant. Optimize fluid administration, so avoid excessive fluids. Resuscitate with hypertonic solutions or colloids, fluid removal, and might need to do diuresis or ultrafiltration. Optimize systemic and regional perfusion regarding the goal-directed fluid resuscitation, hemodynamic monitoring, and adjusting the blood pressure for perfusion pressure. And regarding the surgical decompression, so how it be done, how it could be achieved? You are my professor in this situation. You might have a longitudinal midline facial fasciotomy or transverse. Why? This is the gold standard, the most effective method for tackling this problem, fatal problem, and when actually should be as soon as possible, because if you intervene late, the outcome is still very poor. Where? And this is another situation, because you to push a patient in this situation to OR sometimes refused by anesthesiologist, so, and the patient situation can be moved, so can be done in the ICU. Management of open abdomen, so you will keep your patient open abdomen. A lot of maneuvers, like we have in a couple of cases, vacuum closure, and regarding the complication, all of us know the possible complication for keeping the abdomen open, and nutrition, as our colleagues mentioned before. So, regarding laparoscopy and intra-abdominal pressure, is there any correlation between laparoscopic surgeries and intra-abdominal pressure? So what is the correlation, or what is the relation? Insufflation pressure, yes, exactly, thank you. So what is your insufflation pressure? Just somebody to tell me. 12. 12 ل 15. So by definition, as all of us agree, intra-abdominal hypertension is the cutoff value 12 or more. So if you insufflate pressure 12 or more, you are inducing intra-abdominal hypertension. Actually, when I did review regarding the European Association for Endoscopic Surgery in 2002, maybe like after 15 years of starting laparoscopic surgery, what the panel or expert recommendation? The panel recommends that use lowest intra-abdominal pressure, actually from 5 to 7. millimeter mercury, rather than using a routine or standard pressure 12 to 15 millimeter mercury. This is in 2002. And this recommendation is still valid and insisting and highlighting it till nowadays. And why that? Because it is less pain, nausea, vomiting after with low pressure, no harm regarding visualization, and you are expert in this situation. Actual immune function and cellular effect regarding the better in low insufflation pressure. Intraocular and intracerebral pressure is less, and there are some case reports regarding blindness post-laparoscopic surgery, cardiac problems, and hepatorenal dysfunction. How that? By lower insufflation pressure, deep block positioning, and definitely expertise. Meta-analysis done also for regarding the low intra-abdominal pressure in laparoscopic surgery, and meta-analysis in more than 7,000 patients with 85 studies regarding the low or standard intra-abdominal pressure, and their recommendation according to the available evidence support that moderate to strong recommendation, A1 level, in favor of low intra-abdominal pressure during laparoscopic surgery. And thank you.